Good afternoon, everybody. Thanks for joining me for this review, our updated abdominal and pelvic imaging protocols. Essentially, I started working on these shortly after I took on the ultrasound lead position, with the main intent of getting some standardization and harmonization of the protocols performed across the sites, in terms of both the minimum expected images that are required for our ultrasound examinations, as well as providing some technical considerations and parameters that can be used for image optimization for all of these various protocols. These have all now been passed through our practice committees and approved and uploaded to one THP, so they can be accessed there if ever needed for reference. In terms of this presentation, we're going to find a place to host this, as well as the previously given THP-wide review lecture online as well, so that those can be looked back at if you ever want to refer to them for reference at a later time. So in terms of the protocols that have been revised and approved at present, it's most of our general abdominal imaging protocols. General abdomen or HCC, right upper quadrant examination, appendicitis, portal Doppler assessment, our renal and bladder assessment, as well as a post-transplant renal assessment, and then our both male and female pelvic imaging, as well as groin and groin hernia and pseudoaneurysm imaging, as well as the thyroid images. In terms of the protocols that are currently completed initial revision, but are now being reviewed by various individuals for feedback, it's most of our OB imaging. So stay tuned. These we'll go through at some point, probably in the fall, potentially into Q4. And then the next stage would be to revise the remainder of our currently available protocols and potentially add a couple of additional ones. And most of those fall into either pediatric or MSK baskets. So before we kind of get into the details of the protocols, I just want to say that much of this is really just a review for most, and in general terms, a lot of what we are going to go over is already really being done and being done well. That being said, I think reviewing the revised protocols in detail can go a long way in terms of ensuring consistency in the way we image cases across all three sites, and making us more efficient by kind of clarifying what images need not be obtained for any given study. I think it should also be said that not every patient is going to be the ideal textbook patient. I completely recognize that. From a visibility standpoint, I would say most of our patients are in fact far from this. But I hope by utilizing some of the imaging optimization techniques that are laid out in these protocols, and that we'll discuss, that we can ensure that at least within the limits of the factors that are in our control, the quality of the product that we're putting out from the ultrasound department is not just good, but really truly exceptional. So without further ado, let's get started with our general body protocol. And starting in the midline epigastrium, just going over kind of the expected images. SAG images of the aorta and IVC should be obtained at the level of the epigastrium, with and without color. Whatever parts of the aorta that are visible and not obscured by bowel should obviously be scanned down to the bifurcation to look for any abnormal pathology of the aorta or retroperitoneum, but no transverse images or measurements are necessary in terms of being recorded, unless the aorta is aneurysmal or the study is being specifically done for investigation of the aorta or some retroperitoneal. So that's something that potentially, I know that we do sometimes obtain images in the transverse at various levels of the aorta, and you can by all means obtain those, but I don't think it's necessary. Really, I think the only necessary images are those SAG images in both grayscale and color at the level of the SMA and celiac axis and the left hepatic vein for the IVC. In terms of the pancreatic imaging, again, within the epigastrium, representative images of the pancreas should be obtained. And generally, this is going to just constitute a transverse and sag image of the head, and then kind of a long axis, which is usually in transverse of the head, body, and as much of the tail that can be imaged. But occasionally if the tail is able to be imaged and is not obscured, obviously that's a bit of an oblique angle image off of the transverse axis. In terms of the duct, if the duct is visible or frankly dilated, then obtaining an image with color is useful just to show that it is indeed duct and not vascular in nature. Obviously, I think we already largely do this, but just to make sure that it is done kind of regularly if the duct is visible. In terms of liver imaging, it's a busy slide. I think, again, most of this is already in all of your routines. For the most part, we just need to be taking representative images in sag and transverse, sweeping from right to left and sweeping from dome to inferior tip of the liver. But in terms of trying to get certain images consistently, we do want to have in the sag an image of the right hepatic lobe, including the diaphragm and pleural space, as well as the right lobe with the kidney, making sure that we do see both structures and see if there's any fluid or anything else within Morrison's pouch. In terms of coming across into the left lobe, getting that sag image of the caudate and ligamentum venosum, you may have already obtained while imaging the midline epigastrium. That's this image here. So no need to duplicate if it's already obtained. Similarly with the left lobe, midline proximal aorta and pancreas, that also may already be obtained, and no need to get that image again if it's already been obtained. In terms of the transverse, it's nice to have the dome with the IVC and the hepatic vein confluence. You can always throw on a color Doppler as well to just show patency. Obviously, for routine abdomen, no need to perform any spectral Doppler, but always nice to show those as patent if they're not otherwise seen well on the grayscale. Similarly, left lobe with the left portal vein and right lobe with the right portal vein, and a nice image, ideal image, if possible, at the mid-liver with the portal vein bifurcation. So this is not something that we normally do consistently. So I'd like to ideally get this kind of done consistently at the bifurcation without and then with color. Again, just showing normal directional flow of blood within the portal vein system. And then again, this is something that's probably already done by all of us, but just an image documenting the left lobe in the region of the falciform ligament, again, showing that there's no patent periumbilical vein. More critically important if there's evidence of hepatic disease otherwise, or if the examination is being done specifically for investigation of some hepatic abnormality or hepatic disease in general. So one thing that I think is a bit of a change from our normal practice historically is that if there is chronic liver disease present, that you're seeing either on the basis of coarsening ecotexture, evidence of portal hypertension, or if the examination is being performed for the examination. Sorry, I think someone's not on mute. Yeah, so, or if the examination is being performed for the investigation of hepatic disease or abnormal LFTs, we really should be investigating the hepatic contour nodularity with high resolution linear imaging. Often it can be, this nodularity can be appreciated on curvilinear, but I think it's good practice to if it's not too much difficulty, to also obtain a linear image showing higher resolution of that surface to investigate for nodularity. So here you can see just a correlate image showing that contour nodularity that may be too subtle to really appreciate on the curvilinear, and can go a long way in allowing us to really give a suggestion of whether or not the liver is truly cirrhotic or just some early chronic liver disease on the basis of ecotexture, which I find can be a very subjective finding. Staying in the right upper quadrant in terms of the gallbladder and gallbladder and biliary ducts, really, again, just representative images in long and transverse of the gallbladder. But when imaging the gallbladder, particularly important to include the neck. Sometimes we do get images of just the body and fundus, which is usually sufficient, but particularly if dilated or if investigating for right upper quadrant pain, it's critical to make sure that we have a good look of the neck, make sure that there's no stone impacted in that region or anything else that might be causing obstruction in that region. The other thing that I'd like to highlight is that if thickening is visible on the grayscale images, that we should be obtaining color Doppler images or power Doppler images of the thickened wall and the adjacent hepatic parenchyma to assess for hyperemia. This is again something that we do sometimes, but not all the time, and I think it should be definitely included if there is wall thickening present, as it's quite helpful in differentiating secondary or reactive edema from inflammation in the setting of acute cholecystitis. And then in terms of measuring the wall thickness, generally this can be performed along the free wall if there is ascites present, but otherwise generally is easier to measure along the hepatic wall if there really isn't much fluid present, as it's a little bit more difficult to make out that deep wall. Obviously, it's already part of our tech worksheet in terms of documenting sonographic Murphy's sign, but obviously, if the patient is on analgesia, that this should definitely be documented as well, just because obviously then the assessment of the sonographic Murphy's sign is not reliable. And then with regards to duct assessment, for the most part, try to image as much of the CBD and long axis as possible, but the maximum measurement should be obtained in the porta hepatis. And just to highlight, it's always an inner wall to inner wall measurement of that CBD. And then assessing, measuring the distal duct really only is necessary if the caliber of the CBD is abnormal in the porta. If it's a normal caliber CBD, no necessity to go looking for dilatation more distal to that. So just as a case review or pictorial review of the importance of assessing Doppler flow within the thickened gallbladder wall, just a couple of images for for comparison of some secondary causes of wall thickening, which can commonly be seen in hepatic cirrhosis or acute hepatitis, as well as congestive heart failure, volume overload, any type of third spacing. So in the setting of hypoalbuminemia or hypoproteinemia or lymphatic obstruction. You can see a clearly thickened wall here, but nothing in the way of any hyperemia within the wall there. When assessing for wall hyperemia, and this goes for assessing vascular flow in any pathology as well, it's really critical to make sure that your velocity scale is properly adjusted to pick up flow within small engorged vessels. So really, the scale should be adjusted to something in the range of 3 to 10 centimeters per second, not 25 or 30, which sometimes I have seen some color Doppler images with the scale set too high, and really we can't say much. Alternatively, if you just throw on power Doppler to demonstrate the absence of flow, that's also completely sufficient. So here you can see, by comparison, these two cases of acute cholecystitis. On the right, the wall is thickened and indeed hyperemic, and that there is some hyperemia also in the adjacent hepatic wall. So the other thing that I think we do perform relatively consistently, but it's not necessarily documented either on the image or on the worksheet, is demonstration of stone mobility and, if possible, shadowing of those stones. So I think that for the most part, people are getting patients into variable positions, either left lateral decubitus or standing, to show that those stones are mobile. But if it's not documented on the image, it's hard for the radiologist to really know that has indeed been confirmed. So going forward, if possible, to either show on the image just if the patient's been changed into a different position, if that can just be indicated, annotated on the screen, that'd be quite useful. Or if it can be just explicitly documented on the worksheet that the stones, if they are found, are mobile, then that's quite useful. In terms of trying to accentuate acoustic shadowing, really a couple of different things can be done to try to accentuate that finding and indeed show that these are stones and not either sludge balls or polyps. And that could include something as simple as repositioning the patient so although those stones roll together and produce a larger reflective area, but from a technical standpoint, decrease the gain or power, placing the focal zone at the level of the stones, or increasing the transducer frequency level in order to accentuate that shadowing. For imaging of the kidneys in terms of our routine abdominal protocol, nothing groundbreaking here. SAG and transverse images, with SAG image pretty much at the midpoint of the kidney, and then transverse of the upper, mid, and lower pole. Routine color or power Doppler image, single image at the mid SAG of the entire renal parenchyma, just to show the global perfusion of the kidney. And I think this is a particularly useful image when looking for or investigating possible pyelonephritis, just as the grayscale findings for pyelonephritis can be very, very subtle, and power Doppler, these variable areas of hypoperfusion in the setting of pyelonephritis can kind of accentuate that to some degree. Obviously, it's still a relatively low sensitivity finding compared to CT, but useful if you do see something that looks like potentially a little bit more wedge shaped, some variable echogenicity of the renal cortex in that wedge-shaped configuration, color or power Doppler can certainly help to really nail the diagnosis in those cases. And then the other thing would be, if you do see some separation of the renal sinus fat, just to prove if it's either related to prominent veins within the hilum or due to pyelectasis, just throw a colored Doppler in box on that hilum just to differentiate those two. So just a couple of the key things around renal imaging. As with the gallbladder calculi, it's important to optimize your B mode parameters to document and accentuate any posterior shadowing for renal stones if you do suspect that there are renal stones. And this again can include increasing the frequency range, turning off harmonics or compound imaging if you have those on, and decreasing your compression or dynamic range. Aside from that, useful to throw on color Doppler if you do see something that looks like a stone, just to demonstrate associated twinkling artifact, as it is a little bit more sensitive and specific than our grayscale findings. The other thing that I will say with regards to stones is that very frequently, I think grayscale overestimates the size of stones, particularly if we're measuring the bright reflected echoes, as we commonly do. At least some studies have shown a better correlation of the true stone size at CT or pathology with the width of the shadow rather than the echogenic component. So it can be useful to measure kind of the shadow right posterior to the echo, and that can give a little bit better estimate of the true stone size. Not as critical, but just something to keep in mind. For the other findings that you're commonly going to encounter in the kidney and things around image optimization, for cystic lesions, it's really critical to try your best to accentuate the anechoic nature of the lesion if you do suspect that this is just a cyst. Obviously, that includes decreasing the gain and power appropriately to kind of clear up the internal contents of the lesion, and trying to accentuate any posterior acoustic enhancement. And then aside from that, really just trying to demonstrate smooth walls and exclude any type of nodularity. And then just also always critical to include a color Doppler or power Doppler image of those cysts to just make sure that there, or demonstrate that there is no internal vascularity. The other thing that may be difficult and not possible for all patients, but we should try if you do detect a solid lesion, is just a quick assessment with color Doppler, grayscale and color Doppler, to demonstrate the main renal vein patency as well as the IVC at the level of the renal vein, just to confirm that those are indeed patent and there isn't anything to suggest renal vein thrombus or tumor thrombus specifically. So we've kind of gone over this, and you can see that nice twinkling artifact related to the stone, and the twinkling artifact related to the posterior shadowing as well. So while we're on the topic of renal imaging, and just to keep things a little bit more interesting, I just wanted to take a quick detour and briefly discuss some of the common sonographic mimics that we can see for nephrolithiasis, and what can be done at the time of live imaging to kind of try and differentiate these various entities from stones. Not uncommon that we'll call something a renal calculus on ultrasound, and the patient will go on to subsequent contemporaneous CT, or alternatively will have already had a recent prior CT with no correlate for the described stone. And this is just part and parcel of ultrasound of echogenic lesions within the kidneys. We're never going to be able to be 100% accurate with these, and it can be really difficult to or impossible to differentiate renal calculi, particularly small ones, from some of these entities. But optimizing your technical parameters does give you the best chance of doing so. So far and away, one of the most common mimics for renal stones is vascular structures in the region of the medullary papillae. So the segmental arteries, of which there are 5 per kidney, often cross the papilla at right angles, and then divide near the medullary pyramids into the interlobar arteries that then travel along the sides of the renal pyramids to the level of the pyramidal base. So here on the left, you can see this is actually a case of an interlobar artery that's coursing along the side of the medullary papilla. It's kind of hard to appreciate on this image. It's a pretty old image. This is taken from a case review from 2004. So I think our imaging from a technical standpoint is certainly a lot better. And I don't think these mimics are as frequent now, but I think on our newer machines, you certainly would be able to make out the double line tram track appearance of a vessel. I think if there is vascular calcifications, that's going to complicate matters and pretty much make it impossible to differentiate. But vessel location, configuration, and as well as the lack of posterior shadowing should suggest a vascular entity if that is the case and there isn't any associated vascular calcification. Aside from that, the apexes of the medullary pyramids can project into the minor calyces, and in the setting of mild hydronephrosis can appear quite prominent and mimic stones. Aside from that, they can be even more echogenic than normal and really be accentuated in the setting of early medullary nephrocalcinosis, as well as other various pathologic entities like papillary necrosis and medullary sponge kidney, and those can very easily mimic multiple stones. The multiplicity can potentially suggest that any associated features of those processes can also suggest that. But in the setting of medullary calcinosis, this is really difficult to differentiate on the basis of ultrasound, because generally that calcification within the medullary papillae is going to give the same type of shadowing as the stones. The location is good for stones, so I don't expect anybody to really be able to make that differentiation, but just something to keep in mind. Particularly given that medullary nephrocalcinosis is also predisposing to renal stones, and often those two processes and entities are present concurrently, both stones as well as just calcification of the medullary papilla. So not much you can do to differentiate them, but if there is a known history of those entities, something to keep in mind. Lesions in the renal parenchyma are typically a little bit easier to differentiate from stones, as they often localize obviously more peripherally within the renal cortex than a renal stone would. Nevertheless, some of the lesions, if they are located a little bit more centrally, can make differentiation more challenging. So, a common thing that you can see within the renal parenchyma that can mimic a stone would be a milk of calcium cyst. Often these are going to be seen as a layering echogenic focus within a larger cyst, with a bit of an appearance of a straight line, giving a fluid level and some associated reverberation artifact rather than posterior shadowing. In some cases, the calcified material can really completely fill the cyst and make the differential diagnosis a little bit more challenging. But again, the presence of that reverberation artifact should tip you off to the fact that this is milk of calcium cyst rather than either a parenchymal calcification, or if it's a little bit more centrally located, renal calculus. Here, another potential mimic, we have a junctional parenchymal line, which is essentially just the residual small renal contour notch that marks the boundary of the renunculi that during development fuse to make up the kidneys. And they're often associated with a similarly echogenic junctional parenchymal line that extends from this contour cortical defect towards the hilum and can extend all the way to the hilum. So, if you catch this in transverse, it can potentially look quite echogenic and can shadow and mimic a stone if you're just catching the portion that's closer to the hilum. But when you elongate it, the triangular shape and location should point to the correct diagnosis in this case. So that's essentially, I think we missed the spleen and left upper quadrant structures, but for the most part, really this is just a transverse and sagittal image of the spleen as well as the splenic hilum without and with color Doppler images, and then a general ascites screen of the lower quadrants that should also be included, and that pretty much wraps up the general abdomen. So just moving on to the HCC protocol, really for the most part similar to the right upper quadrant portion of the general abdomen. So for the liver, same routine images of the liver in grayscale and color Doppler, as well as those high resolution linear images of the capsule and underlying parenchyma looking for nodularity. And I think this should be included in all of these HCC screening examinations. And then in terms of the hepatic Doppler examination, specifically if this is being requested as part of the HCC screening exam, we do a little bit more of a extended color Doppler exam of the portal and hepatic venous system. But a bit of a change from what we've been doing historically. I think what I've set out in this protocol is that we can limit the number of spectral Doppler images being obtained to really only the main portal vein and a single hepatic vein. The other veins should be assessed with color Doppler to demonstrate patency and correct direction or appropriate direction of flow. But in terms of obtaining a spectral waveform, unless you note a filling defect or some abnormality in the main hepatic vein or within the IVC, really, I don't think we need to be doing spectral Doppler examinations of all three hepatic veins and main right and left portal veins. We can just limit it to these two structures. So in terms of picking the hepatic vein, really pick the one that's most clearly visible and easiest to find. Sorry, just to address Chantal's question with regards to the right lower quadrant and left lower quadrant examination for ascites. I think it should be routinely obtained on all abdomens. I don't have a good answer from a billing perspective if that would qualify as also a limited pelvis. I believe it may. Let me clarify that, and I will get back to everybody. Okay, so it does seem that that those would constitute a limited pelvis, and so yeah, I think we should be including those routinely. But I'll again clarify and get back to everybody on that afterwards. So for the remainder of the HCC screening exam, really gallbladder, bile duct, spleen, and ascites is same as the routine abdomen, same as what we're doing routinely already. Really not much to add there. So just to kind of quickly go over that portal venous Doppler examination, but more specifically towards TIPS assessments. There is a section within the portal vein Doppler SOP that discusses the assessment of a TIPS. Really, I don't think it's something that we're doing all that frequently. In fact, I think I can personally count on one hand the number of cases I've seen in the 3 years that I've worked here. That being said, given how infrequently we do them, I think it's probably good to have a clearly defined protocol that you can follow in the event that you do have to scan one in the future. Just to go over what we should be doing for those in general terms, that's going to require a grayscale and color Doppler assessment of the entire TIPS length to document patency and caliber at the various levels. The other thing that needs to be done is to measure the distance from the distal margin of the stent to the IVC. Sometimes these stents are placed into the right or very occasionally the left portal vein in terms of the caudal end, and there may be a variable length of the hepatic vein that is preserved from the vein to the IVC that needs to be measured. In terms of assessing the caliber of the stent, just measuring the stent at the caudal end, the midpoint, and the cranial end is probably sufficient, and then any variable portion of the hepatic vein above the stent should be measured to assess the caliber there, as well as with spectral Doppler to assess for flow velocity. Just one point around assessing hepatic vein flow. Really, this is best assessed during suspended respiration, or if that's not possible, shallow breathing, just as the waveform can be dampened a bit by deep inspiration. But obviously, if visibility is limited due to the patient's condition, then do what you can. And then in terms of spectral assessment for the remainder of the structures, it does require an angle-corrected spectral waveform with peak velocity through the various portions of the shunt. So again, at the caudal portal venous end, the mid portion, and the cranial IVC end. So that can be done at the same time as measuring the vessel caliber. If stenosis is clearly visible at grayscale, the velocity should be measured at the level of the maximal narrowing and then distal to it as well. Aside from that, flow direction should be acquired with again angle corrected spectral waveforms of the main right and left portal veins. So I know it's quite an extensive vascular assessment, but generally we don't do many of these. So if we do the infrequent times that we do them, we should be doing them in this way. So just from a quick review of the anatomy, just what you can expect if you do come across one of these. Generally, the shunt is most commonly from the junction of the right hepatic vein with the IVC cranially down to usually the most proximal portion of the right portal vein, although some common variants again do have it going from that right portal vein to some variable length of the right hepatic vein. Less frequently they will anastomose to the middle or left hepatic vein, but typically it is going to be on the right side. And then in terms of what you'll commonly see, really blood's going to be preferentially diverted through this low resistance shunt. So generally you're going to encounter hepatofugal, so towards away from the liver towards the shunt in both the right portal and left portal veins until you get to the shunt, and then you should have antegrade flow within that shunt up to the IVC. And you should also have antegrade flow in the main portal vein coming up to here. So that's generally what should be expected with these. So here you can see within the main portal vein, you're having that antegrade flow. Generally, what you're going to be seeing. So really and truly, the flow directions and velocities for these cases are from the radiologist's perspective need to be interpreted in the context of prior examinations and are far more ambiguous when taken in isolation. That being said, there's certainly some findings that can be seen in isolation that would suggest shunt failure, and these are what we're really looking for with these exams. So in most cases, shunt malfunction is going to be a result of either narrowing or occlusion of the shunt, and this generally occurs within the hepatic vein above the stent or within mostly the cranial portion of the stent, and can be caused either by intimal hyperplasia or by in situ thrombosis. So again, stenosis or occlusion really can occur anywhere in the stent, but most commonly occurs in that cephalic uppermost portion. Really, occlusion is going to be the easiest type of failure to detect, as it's going to manifest by absent flow on color Doppler ultrasound with an aphasic spectral waveform. So really, that needs to be documented with color Doppler and ideally portal Doppler, demonstrating really that there's no flow within the stent, and then throwing on a spectral measurement to show again that there's an aphasic waveform in that region. Stenotic malfunction is going to be a little bit more challenging, but direct signs that you can see potentially are going to include abnormal velocities, either a high velocity or abnormally low velocity within the shunt, or an abnormal change in velocity compared to prior examinations. Other indirect evidence is going to include switching of the direction of intrahepatic portal vein flow from previously hepatofugal to now hepatopedal flow within those right or left portal veins, lower velocity in the main portal vein, lower than 30 centimeters per second, or ancillary findings of recurrent portal hypertension, so recurrence of collateral vessels like a recanalized umbilical vein, or new or worsening or recurrent ascites. So here, just as a nice little case demonstration, this is in the cephalic portion of the stent. You can see quite a bit of turbulent flow through this level with possibly some obvious narrowing of the color flow in that region, and then the angle adjusted velocity is measuring at 240 centimeters per second roughly, so quite elevated and suggestive of some stenosis in that region. Just moving on to our limited KUB examination, really pretty similar to the routine abdomen, except that on the grayscale imaging should routinely include SAG images of the parasagittal portions of the liver, so far medial, of the kidney, far medial and far lateral. So those should be mostly just cortex, as well as the additional midline SAG that we generally get with the routine abdomen. And then where possible, really at least one image showing both the liver on the right and spleen on the left in combination with the kidney on the same image to show the differences in echogenicity between those two. That's something that I find we kind of do inconsistently, and I think we need that routinely on all abdomens for hepatic echogenicity, and then for these KUB examinations with liver and spleen to show renal echogenicity. And then in terms of the urinary bladder, again, nothing groundbreaking. SAG images of the far right lateral, midline and left lateral, transverse, dome, mid, and base. Really, in terms of the Doppler images to show ureteral jets, I don't think this needs to be done routinely, only if hydro is seen or if the study is being done for investigation of renal colic. Otherwise, no need to sit around waiting for ureteral jets. It doesn't really add much from a positive or negative predictive value to our examination. Even in the setting of renal colic, the absence of a ureteral jet doesn't necessarily mean anything. So I think we should de-emphasize the need for doing these routinely. In terms of bladder volume, really only needs to be done when specifically requested or if hydro is present and the bladder is full. If hydro is present and the bladder is empty, I don't think there's any need to do bladder volumes, but you should be doing pre-void and post-void volumes if there is hydro present and the bladder is full, then do some post-void imaging of the bladder and document if the hydro persists or has resolved due to emptying of the bladder. If you do see any debris within the bladder, just take a cine clip demonstrating some mobility of that debris, either while repositioning the patient or just putting some variable pressure to show that the debris is present. So I just wanted to go over the post-renal transplant SOPs as well. So this is probably a bit of a more drastic departure from what we do routinely at some of the sites, and includes a little bit more of an extensive Doppler examination than we've routinely done previously. So in addition to kind of the general grayscale images of the native kidneys, those can be pretty much limited to SAG and upper, mid, and lower pole transverse grayscale images. Obviously, we need more extensive imaging of the transplant kidney itself, same as would be done for the KUB protocol in the native kidneys. So para midline sagittal images, and then the transverse images of the upper pole, mid, and lower pole. Quick survey of the surrounding area for any perinephric collections or other pathologies in the either right or left lower quadrant in the region of the transplant, and then the Doppler examination, which is a little bit more extensive. For the most part, it's going to constitute the same sagittal color or power Doppler imaging of the mid-sagittal to show the overall perfusion of the transplant kidney, as well as spectral tracings of the parenchymal vessels, one in the upper, mid, and lower pole, for the RI values in those three different areas. So those don't need to be angle corrected. We're looking at a relative measurement, so no need for angle correction in those. But we also do need to assess the transplant renal artery for patency and flow velocity. And because we're assessing for flow velocity, those images do need to be angle corrected when you're obtaining those spectral tracings. So generally, that's going to require a velocity measurement at the hilum of the transplant kidney, mid-vessel of the renal artery, and then near the anastomosis of the renal artery. It's also good to obtain a angle-corrected spectral tracing of the external iliac artery just above the level of the anastomosis, because that can be useful in looking at flow ratios between the anastomotic artery, renal artery, and the external iliac artery. But that can be limited to only if you do find an elevated renal artery systolic velocity. So anything above 250 centimeters per second in the renal artery, then I would say also do that external iliac, this should read artery measurement just above the anastomosis. And then in terms of the renal vein, just need a color Doppler image showing patency. I don't think really we need a flow velocity if the vein is clear of any clot or any obvious stenosis. So just in terms of image optimization, it should be noted that it's kind of critical to make sure that the bladder is empty before doing the Doppler assessment of the parenchymal vessels, and less important for the renal artery, but at least for the parenchymal vessels, because if there is pelviectasis, this can artificially elevate the RI measurements within the parenchyma. So make sure that the bladder is empty if you do see that there's any pelviectasis before doing any parenchymal vessel assessment. So here's just a couple of images showing kind of the angle corrected vascular assessment at the mid portion of the vessel in what's otherwise a relatively normal person. So here the angle corrected velocity was around 130 and was within normal limits. Oh no, sorry, this one was a little bit elevated here. And then downstream of the stenosis, what you can find, particularly if the stenosis is quite tight, is you'll end up with a decreased velocity with this tarvis parvis waveform. So a decreased slower upstroke and downstroke of the systolic velocity. So if you haven't already seen it, this is the revised renal transplant worksheet that can be used for these assessments, and includes spots to record those various PI measurements, as well as the systolic velocity, peak systolic velocities in the renal artery. Moving on to our limited appendicitis protocol, most of the abdominal portion of the examination is really not all that different from what we're already doing routinely, and is similar to what we would do for the abdomen protocol. So in terms of the limited images of the kidney and gallbladder and bile ducts, similar to what you would do for a routine abdomen. Nothing to really address from that perspective. In terms of the assessing for the appendix, if we do identify it, obviously obtain long images through the length of the entire appendix, and at minimum document images in long axis at the base as well as at the tip, showing origin from the cecum as well as the blind-ended tip, and then some representative transverse images through the length. As we usually already do, split screen images with compression and measurements outer wall to outer wall. And then something that I don't think we always do, but I'd like to see going forward, is a color Doppler long image at the largest diameter of the appendix, or at any other portion of the appendix that has abnormal appearing appendiceal wall. And then obviously document any other periappendiceal findings if present, like echogenic fat or fluid. So just to quickly review the normal gut signature of the bladder wall, or sorry, of the bowel wall. Really for appendicitis, the greatest sensitivity finding on ultrasound is going to be outer diameter measurement of the appendix greater than or equal to 7 millimeter. That being said, the appendix can be enlarged up to this size for other reasons. So documenting those other supporting secondary findings of acute appendicitis or alternative diagnoses is also important. And one of those things is potentially this loss of normal gut signature, which, as we all know, is made up of 5 alternating layers of hyperechoic and hypoechoic tissue. serosum, muscularis, submucosa, deep mucosa, and superficial mucosa. Generally, these will be relatively preserved in early stages of appendicitis, but as you progress to the gangrenous stages of appendicitis, often you're going to start to lose the differentiation of those walls. Here you can see in this case of a tip appendicitis, nice preserved wall more proximally, and then as you get to the tip, you start to lose those various layers. What I would say is if you do find that you start to lose those layers at any portion of the appendix, throw on a color Doppler box to show if there is any hyperemia. Again, make sure that you adjust the scale appropriately to demonstrate vascularity in that region, as well as any hyperemia in the surrounding soft tissues. So the female pelvis, I'm going to hold off until our next in-service next month, just because we're going to do some additional review at that time of some changes to the medical directive around probe insertion. So stay tuned for that. Just to kind of round off our whirlwind of the revised protocols into the pelvis, just starting with the male pelvic scrotal ultrasound. Really, again, nothing groundbreaking. The expected usual sagittal of the long axis image of the parasagittal, medial, and lateral, and then the midline as well as the transverse grayscales of the upper, mid, and lower pole. Critically important to include at least one midline image of the scrotum that includes both testicles, both without and with color Doppler, allows to really clearly see the differential echogenicity of the two testes, as well as differential flow, either absent flow in the setting of torsion or hyperemic flow in the setting of epididymoerychitis. It doesn't need to include the entirety of both testes, and it's going to be difficult to capture both of those on a single image in some cases. So really just some image, including a reasonable portion of each of those testicles in grayscale and color. Aside from that, one thing to note, if you're unable to get the two testicles on a single image, in the setting of undescended testicle, then use a split screen image with the same scale of Doppler to show both the left and right on a single image to show that relative flow between the two. Again, in any cases of pain or torsion, and this goes for ovarian torsion as well, or investigation of pelvic pain in a female, we really need to make sure that we're obtaining as best we can arterial and venous waveforms in both the testicles or both the ovaries. Obviously, this is not going to be possible in every patient because of technical limitations, but generally, at least in the scrotum, this should be possible to get those both. Only other thing to quickly note would be if an appendix testis or appendix epididymis is seen, just obtain both a grayscale image as well as a color Doppler image showing vascularity within the appendix, particularly if the investigation is for acute pain, as these can be a common mimic from a clinical standpoint for testicular torsion. So the torsion the testicle itself may look completely normal, the epididymis may look completely normal, but then the appendix itself is torted, and generally, if it's a little bit later stage, the torted appendix is going to start to look much more echogenic on grayscale imaging. So that's going to be apparent on your grayscale images, but throw on a color Doppler image, as this will accentuate the lack of flow within the torted appendix and can really seal the diagnosis that is the case. And then the remainder of the scrotal examination, similar to what we're already doing generally, is your transverse and sagittal images of the epididymal head, a single sagittal or a couple of sagittal representative sagittal images of the body and tail, with a thickness measurement of the thickest portion of the epididymis, and allows for side-by-side comparison of those two structures, and then representative color images of the head and body and tail being done at the same time as those grayscale images. One thing that I don't know if we do all that routinely would just be a single transverse image of the scrotal wall, the bilateral scrotal wall, with and without a measurement, if it is indeed abnormal. If it doesn't look abnormally thickened, no need for a measurement. But if it does look abnormally thickened, just please give a measurement of those two sides if they are variable. And in terms of doing that measurement, it should be from the inner echogenic tunica vaginalis to the outer skin surface with no or very minimal probe pressure. Aside from that, long images of the inguinal canal with and without color Doppler, just looking for any herniated abnormality in those, or any other abnormality. One of the small changes, I think, from what we do routinely at some sites is I think we're commonly measuring hydroceles, and I don't think we necessarily need to be doing this on a routine basis. Most of us don't actually report the measurements, and generally not all that useful. For the most part, we can really just be grading these from a subjective perspective. Are they small, medium, or large in size? And then really just documentation of any mobile debris, similar to with the bladder. Just provide a cine if there is debris, just showing mobility of that. And then in terms of the varicoceles, if you do see something that suggests varicocele, and the vessels do appear a little bit prominent, grayscale and color Doppler images on split screen, without and with Valsalva or standing, and then measure the vessel diameter on split screen, but this should specifically be done on the grayscale image, inner wall to inner wall, both without and with Valsalva on those split screen images. I think we'll try to. I have a couple of more slides about the groin that I think we'll try to go over maybe at the next in-service, just because I don't want to run too far over time, and I don't want to rush through these, given that there's a little bit more to discuss. So let's hold off on those until our next in-service, and maybe I'll just take some questions or comments if you guys do have any questions or comments. One thing that I will say, if you do want to have a little bit of a review of the Doppler imaging in the liver or the transplant kidney, there's some excellent radiographic articles that, obviously there's more information than you may need, but there is quite a bit about technique and expected findings in those two structures. So this radiographics article from 2011 for Doppler ultrasound in the liver, and then one from more recently 2019 about imaging of renal transplant complications. So those would be excellent references if you do ever want to have a little bit more of a read about those types of techniques. So I'll just pause here and go over things if there's any other questions. So I saw that there was a question, if we're doing spectral Doppler for HCC assessment, are we billing for abdomen and Dopplers? So yes, that should be billed with Dopplers if we are doing a spectral assessment. But generally, we're only going to be doing a spectral assessment in the HCC if it's being requested. I don't think it needs to be done routinely once we've already done it once. And then for the cirrhosis liver abdomen scan, if they have ascites, are we going to be doing a liver Doppler as well? So I don't actually have a good answer for whether or not we should be doing those routinely unless they're specifically requested. I think at the moment, I would say that we should just continue to limit it to documenting portal vein patency, like doing what we would do routinely for these. So a color Doppler examination, but not necessarily a full spectral portal vein examination. But that may change. What I am planning to do is put together a separate document. And this is kind of in the works for not just the HCC, but more broadly to kind of give a little bit more direction about a little bit more of a flow chart of what to do in terms of what types of examinations and what portions of each examination in what clinical circumstances or when certain imaging findings are found. So some of that already is included in a more detailed way in the protocol documents. So more specifically for the pelvic, female pelvic examination, there's specific indications to include a full abdomen or to include a transvaginal examination. That's going to be done for all of the abdominal imaging protocols as well, but as opposed to including it specifically in the protocols, this is going to be a separate document and probably will require some policy around that as it may include a directive that will allow you to automatically extend or limit examinations as are necessary, depending on the flow chart as it's set out. So, sorry again, just to go back to the HCC. Oh, sorry, that's correct. So yeah, so we do include those spectral Doppler waveforms. Oh, sorry, no, it is again, only if requested. The hepatic Doppler examination is going to be included in the HCC screening. Otherwise, really, we just require color Doppler of the main right and left portal veins, as well as the hepatic veins to confirm patency and appropriate direction of flow. The full hepatic Doppler examination is only necessary if it's requested, at least for the time being. That again may change, but for the time being, that's what we're going to limit it to. Is there any other questions about any of the other exams? So with regards to SMV and splenic vein, I believe it is written out in the protocol. I'm going to have to check again, but I believe there is a color Doppler image that is included for the splenic vein and SMV, but again, just to document patency and direction of flow. No spectral tracing is required. I know we have been doing spectral tracings routinely of the splenic vein, but this isn't necessary going forward. We just need to confirm patency and appropriate direction of flow. If there's no other questions, I think we can wrap things up. If you do think of anything or have any other further comments, and really I'm open to any comment about what you think about technical feasibility or challenges that you might anticipate with any things that we've discussed today. I'm going to be making similar changes to all of our protocols. So if there's something that you think that it's critical for me to know from your perspective, please feel free to email me with any questions or concerns regarding that. The other thing that I'd ask is if you can please start collecting any interesting cases that you come across from a sonographic perspective. If you've scanned them personally and you followed up on them, or if any of the radiologists have mentioned them to you after the fact because they've found that there's an interesting CT or MRI correlate, please forward those along to me. I've been collecting some myself, and I'd like to start doing some interesting case rounds with all of you guys in the fall. Hopefully, if we have some time left over for our next in-service in September, I have a couple of cases already that I'd like to. So please forward those along to me if you do encounter those, or if you have any that you've come across historically. So I know that a couple of the sites do keep books of interesting cases, as was just mentioned in the comments. It's hard for me to go and go through those unless I'm on site, which unfortunately I'm not on site all that frequently at all the sites. So if you do have any cases that from those books are high yield from a teaching perspective, or are really interesting, please feel free to just send me an email with the accession number, or send me a message through Sectra with those. All right, if that's it from everybody, have a great afternoon. Thanks again for joining, and again, email me if you have any questions.